Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
And today we're going to do not so much an article. We're just going to kind of opine about the press release that came out regarding the INTerpath-001 study. But maybe before we do that, James, let's do a quick fire. Okay, this is more of a quiz than a quick fire. Which of your favorite TV actors has an associate's degree in ballet?
An associate's degree. I'm not going to tell me it's Alan Richardson, are you?
It's Alan Richardson.
Oh, bingo.
Yeah. He met his wife in ballet class, and then when he pulled out of college, he had enough credits to get this associate's degree in ballet. He was a big musical theater. He's a vocalist. He said he got multiple scholarships on his voice alone. Has he sung in anything that you know of?
No, but wow, that's amazing.
I know.
That is amazing and cool. That just popped into my mind. The other person who I think surprised me a bit when I found out that they were a fully trained dancer and I think possibly a singer is
technical difficulties notwithstanding. We've probably also switched spots on screen, but I can fix that.
Like it. No, I was just saying somehow it reminded me of the other person who I found out was, I think, a fully trained dancer, which I hadn't realised. Also, big Hollywood star, but maybe not so much now. Can you guess who I'm going to say? It's not someone you'd associate it with. Christopher Walken.
Oh, wow.
Yeah, fully trained and probably so that was his thing, actually. I think dancing before he became famous. That's quite an interesting fact. I'd need to check that, actually, but I'm pretty sure. Because when I found out, I was just amazed because he had a lot of these kind of like horror type roles as he got older. But actually, the guy was a fully trained dancer. He's in quite a lot of those Tarantino films, actually, just maybe with small parts, from what I can remember anyway. Very sinister. And like you say, kind of breathy sort of voice, actually. A great actor, I would say, as well.
You're not thinking of Harvey Keitel?
No, I'm not thinking of Harvey Keitel. Thinking Christopher Walken, actually. He was in that film Catch Me If You Can, I think, as well as the father.
Yeah, as the father, yeah.
Yeah, I thought that was a nice role as well, actually.
Cool. Yeah. Cool. Okay, so on to the press release that came out on August 19th, did we decide?
Yes, I think so. That's right. Which is a Wednesday. Yeah.
Merck and Moderna announced phase 3 INTerpath-001 trial of intismeran autogene plus Keytruda met endpoints of recurrence-free survival and distant metastasis-free survival in patients with completely resected stage 2B to 4 melanoma. Okay, it was an interim analysis. So, do you remember the primary endpoint?
Oh, yeah, but the press release said RFS and DMFS, statistically significant. And then
so RFS is the primary, DMFS is a key secondary. It says they're waiting for other key secondary, including OS. But, okay, so there's no numbers here. There's no hazard ratio. There's nothing to speculate. We just know that it's statistically significant and clinically meaningful. So I guess my question to you is why, if that's the primary endpoint, my understanding is this isn't going for registrational review based on this. They are going to wait for OS, right? But is that necessary if it's a secondary endpoint?
I don't know the answer to any of that, honestly. I mean, all I was kind of going to say was that the statistically significant bit is binary, yes or no, and then so that's objective, and but the subjective comment was about clinical significance, because that's the other bit of this that it says in the press release. It's clinically significant, but I think we all need to wait till we see the data. And of course, and I've said this before, the efficacy is one thing. I think it will be nice in a good sized phase 3 study to see the safety as well. I think so far there haven't been any real issues about that, but I'm kind of looking forward to seeing that. And of course, as you've already said in the introduction, the issue here, I think, in many ways, is the stages of people with melanoma that went into this trial. So 2B to 4 adjuvant, obviously, and obviously the critical issue there is the neoadjuvant. But I'll go back to you to maybe say something about that.
Well, remember when we talked about the phase 2B Keynote 942 study, when we talked about it in our Best of ASCO, we may have done a recording on this that's sitting on the shelf. So we may have to dust that off and actually publish it or just re-record it. But that phase 2 study, do you remember the big thing there that was for resected stage 3 and up? It was mostly stage 3C. It actually wasn't that many 3Bs. 3Bs, there's a lot of reasons for that. It was their eligibility criteria. Their criteria, you couldn't have been in your first episode of 3B. So you couldn't be a melanoma with a clinical lymph node that would be eligible. You had to be a melanoma that is now recurring with a clinical lymph node, i.e., 3B in your second episode of melanoma, and then you're eligible. It's a little confusing why, but they said they wanted the highest risk patients in that study so as to have the kind of shortest readout. And then compare that to this study when you take 2B patients, that's a lower risk population that's going to take longer time to read out, at least for things like OS. So yeah, these are different populations in the phase 2, but pretty cool that phase 2 had a signal for RFS, DMFS, and the phase 3 is having a signal. Phase 2 had an OS signal too. We'd have to go back to that episode and remind ourselves if it's mature or still immature. And then I guess the question would be, let's say, so this is, positive for RFS, DMFS, great. We have yet to have an adjuvant PD-1 based therapy that has an OS signal. What happens if this one doesn't have an OS signal?
Well, I mean, I don't think we're going to find out anytime soon. That's the first thing to say. I mean, I'm not privy to any sort of information here.
No, but how does utilization of this regimen, how do you think about it in your clinic if there's no OS signal?
Well, first and foremost, getting back to neoadjuvant. So for palpable stage 3, let's just talk about palpable stage 3. We already know the benefit from S1801 and Nadina in terms of a neoadjuvant approach there. So that would be my question straight away. In those stage subgroups in this trial, how does that compare? And then for the non-neoadjuvant suitable, let's just say that. Honestly, I'll also be looking at the magnitude of benefit there against single agent pembro and the safety, of course, as well. And I think, assuming it is well tolerated, which I think is the most likely scenario, and you've got a significant delta in terms of efficacy, then that honestly will be quite compelling for me, is what I would say, subject to all the usual caveats. I mean, I'll say something else now, which I'm talking because this is in the public domain, isn't it? The Moderna share price between doubled and tripled the day that this press release came out. So there's a lot of excitement and anticipation here, and it isn't just because of melanoma. That's, I think, one of the key things here. Go on.
Well, that's it. The interesting thing to me is that this is not a broadly applicable disease state, right? This is melanoma, and from this very small type of cancer in the bigger scheme of cancer, and then the bigger scheme of things that Moderna is treating, for that to do this to your share price, wow. That, I think, tells you and me, and I think it signals to the oncology space, this is going to quickly change the paradigm in oncology beyond melanoma. It's not going to just be melanoma that can develop this fingerprint for a patient's cancer and then give prevention. Where to place this in clinic? Look, we're using adjuvant therapy right now without an OS benefit. I think many of us are giving it, I give dabrafenib trametinib, which slightly missed an OS signal there. So I think this for me doesn't, if there's no OS benefit, it doesn't diminish my enthusiasm for wanting to do this. It just kind of falls in line with many of our other adjuvant therapies. And you and I have talked about this with kidney cancer. I mean, the bar for showing an OS benefit is almost unreachable. That's not the ask in adjuvant therapy for kidney cancer, right?
Yeah, I mean, just quick digression. So pembro in kidney cancer does have OS benefit, single agent, and then the FDA have now approved pembro belzutifan, but that RFS benefit versus pembro alone. And then the question there is, are we going to see an OS benefit? But the trial, that was the first readout of the trial, which was quite recent. Shout out to Tony Shuari and colleagues. So we'll wait and see, and I'm open-minded about that question as well. But I agree with what you said about adjuvant treatment. At the end of the day, if you've got a patient in clinic, got access to the treatment, I can't see how you wouldn't have a discussion with a patient about it, actually.
Small things that will come out in the wash that we'll have another episode about down the road, I'm sure, is just sort of like the logistics of it. Do you get all 9 vaccine doses delivered up front? My understanding is no, maybe not. And, small things like that. Yeah.
Yeah, no, I was just going to say, I think the operational stuff actually shouldn't be taken for granted. It's pretty important, this. It's all doable, but it's a classic example of when you're doing a clinical trial, that's one thing, but actually operationalizing it, I don't really like that as a verb, but anyway, operationalizing it subsequently is important. And, we shouldn't just sort of shrug our shoulders about that. It really needs to be thought about properly. Sorry, go on.
So what do you take about this comment? The president of Merck, who says, together with Moderna, we look forward to presenting data from INTerpath-001 at an international medical meeting and sharing with regulatory authorities.
Yeah, sounds good. Watch this space, eh?
I guess, yeah. Okay. Well, thanks for opining.
You too. Thank you.